All right, welcome to Her Body and Mind podcast. My name is Dr. Ciera Fox, and this is Amanda Sarich.
Hello.
Registered clinical counselor. Today we are talking about tired moms and why they don't get offered blood work when they go into their healthcare provider saying that they're tired. So we'll talk about that, and then we'll get into specifics with, you know, if this is you and if this has been your experience, we're going to tell you the exact lab tests that you can run and how to go about testing. So the time of day that you should go, what you need to avoid prior to make those lab tests as accurate as possible. So then you truly do know if there's other factors going on in your life above and beyond just being a busy mom that are causing your fatigue symptoms.
Knowledge is power.
Yep, totally.
So we talked about this in our last episode. So look back for like more kind of information about this first kind of piece we're going to talk about. Mm-hmm. But still, like, what are some of the reasons that women are not being offered blood work? Like, I'll speak to it in a second, but what do you think from your experience?
Yeah. So I kind of using this here of like a woman actually going into their GP or whoever, could be anyone, NP, ND, saying that they're tired. Why are the labs not actually getting run that should? And there's a lot of different reasons for that. I would say if it's a new mom, they're just assuming it's because they're a new mom and they have a baby and you're supposed to be tired. We kind of talked about this last time. It's like expected that you're getting up through the night, etc. Like you're going to be tired. Just wait. It'll get better. So that's like a common scenario that comes up with new moms. I feel like with general practitioners in my mind before this is like, well, like, you know, there's a lot of male doctors out there and that could be a reason because they just don't get it. They don't really think, oh, women are losing blood because of their periods or they just lost blood because of having a baby or all these things. But then I actually I ran a search, ChatGPT, like we all do, and looked at statistically in BC, Canada, what percentage of doctors or GPs specifically are male versus female. And 51% are men and 49% are females at this time. And I do hear this often. I'm always shocked. My patients will say they have a female practitioner with kids themselves, but just as far as this picture goes, their fatigue, their mental health, it's like, here's this antidepressant. Right. This is the reason why you're tired and your moods are low. Like move. I'm like, what? They have small children too? Like, I just don't get it. I can't, they have the lived experience and yet they too are probably gaslighting themselves and minimizing their own symptoms and just pushing on.
Well, it's all about the lens we see the world through.
Yeah.
So it's like part of it's like your own training and it's like different from different practitioners to practitioners.
Yeah.
I think it's like societally the lens to which we see the world through. And if we see, like we always talk about, like you can't know what you don't know. And like you can only kind of go as far as you've gone. So it's like women in general are like minimized and we minimize ourselves. And so that's going to play into all of it. Right. Plus training and just like all of those other pieces. Absolutely.
Totally. So I would say like that's like in a nutshell, probably like the more common things as far as like you go into your doctor and this is what they say is
like, you're fine.
Yeah.
Kind of like the perimenopause stuff. It's like, oh, here's an antipsychotic. Have a good day.
Yeah. Totally.
Instead of here's some hormones.
Yeah, totally.
Yeah. And I mean, like this is going to happen for a lot of people. You hear this on repeat. There's definitely good GPs that are like taking women seriously.
Totally.
Like we talk about how we don't want to like man hate. We also don't want to GP hate.
No, you have a good practitioner. I have a really good practitioner as far as GPs go. Like
good.
They're very, very good.
But there's a mixed bag in all practitioners. There's not great counselors. There's not great naturopaths, but it's like this like collective experience that you hear on repeat
totally
is like people not getting kind of like heard in these spaces of healthcare. And like that is something we are wanting to talk about.
Yeah. And that's why people end up in my office. Unfortunately, it's like they need, I am an alternative to them because they're like, well, I'm not getting heard. I'm just so fed up. And I know something's wrong. Please help me. Like they're desperate at that point. I'm like, okay, like this is pretty simple. We can take care of this.
And a lot of people don't even have a GP. So it's like a walk-in situation, phone, quick, not enough doctors, not enough resources. Like our system is a dumpster fire. And then, which we talked about in our last episode, is also just, again, the lens that women should be tired because it's expected that women carry more of the emotional load, and expected that women feel the impact of that in which we carry. So it's like a lot, right?
Totally. And then let's say that in the example where a woman does manage to get a lab requisition, what happens when they actually do run blood work?
Yeah.
So there's a few scenarios. One is that they're like, well, you know, my doctor said that like they ran everything and everything's fine, and they'll bring the rec into me. And there's a few different situations that can arise. There's one where they just ran a CBC and nothing else, which is just your red and white blood cells, but there's no iron and no B12, no D, like nothing, no thyroid. Enough. They're like, well, they said that my iron's okay, but then really nothing was tested tangibly to show anything. So I'm like, okay, well, we're missing this, and this. So we can't really say that yet, right? Or they do get the labs done and they're just told they're within normal reference range, which often they are. They're within the normal reference range, but being in the reference range doesn't mean that you're optimal and you're actually feeling well within it. And that's another nuance in training, like what we're taught versus, and not even taught, it's what research we cite and use to then dictate where we intervene. The regular medical model has to cater to millions of people, and therefore they have to keep the ranges wide because they can't accommodate treatment in a more narrow range. Versus we know research tells us actually what ranges you feel well in and don't feel well in. We just don't use those ranges when we're developing these like lab and diagnostic testing because of it. So that's another thing. Yeah.
Okay. So they go in, and some of the reason is they're not being like given like the ideal tests, or the tests are being interpreted from a model based on like mass, or a model based on maybe even men, or just whatever it looks like. If we talk about mental health, a lot of the diagnostic criteria is like based on men and not taking like women's realities into account. So it's like those nuances exist, I'm sure, too, in medical testing, right? Like who is the base of this based on?
Yeah, they do kind of change things slightly, particularly for iron, women versus men, because it's more likely that men will go into iron overload versus women not. So like even for that, they do have different ranges and what's acceptable. Or if you talk about pediatrics, there's different ranges. And so actually for peds, if we're just using iron as an example, it's actually easier to qualify as being iron deficient in that age group. So for example, I think it was a 10-year-old male who the bottom of the reference range was 30, but for a female who menstruates who is over age 18, it's 15. You know what I mean? But they recognize like pediatrics. They're like, okay, well, we know that symptomatically, like they're going to be symptomatic at that range. It doesn't mean that we're not. It's just they've applied that. So they make it easier for peds too. Yeah. So
another reason.
Yeah.
So there's all these reasons, but if we are to find a practitioner, which is a challenge in itself, right? So, and I think that needs to be noted too, because it's not that you're doing anything wrong. It's like really hard, and it shouldn't be, but it is, to even find a good practitioner, a good naturopathic doctor, a good medical doctor, good nurse practitioner, right? Always variance in all careers. But if we find ourselves in front of someone who we trust, who we feel like we can ask these questions for, what if I was sitting in your office as a delightful patient, would I ask you for to be able to kind of dig in a bit if I'm like feeling like my fatigue is more than it should be?
Yeah, totally. So like if you're seeing me, and let's say we're trying to use MSP and our medical systems to support what you need medically, and through me, lab and diagnostics, everyone has to pay out of pocket or use their benefits to cover. So we're often trying to get support of general practitioners so MSP can be billed, which makes sense because you are unwell, and that's what it is meant for, is to support you and your health, and you pay taxes for this. Anyways, I digress. So I always tell people, lead with your symptoms. You have to. You can't just go into a practitioner and be like, you know, Dr. Fox on her podcast said that I need these done. Please do them. They won't be happy about that. But what they will do is, if you can relay your symptoms in a way that makes them understand how those symptoms are impacting your health and your ability to function your day to day, they'll be like, yes, this makes sense medically for us to test this because your symptoms are in alignment with this said deficiency that we want to test for, which we went over like a symptom list last episode for all the tests that I'm going to go over. So you can flip back to that. But yeah, express what you're experiencing and how it's impacting you, and then say, can we please run these?
Which is actually kind of a hard thing to do, because I talked about this last episode as well, is that women in general, particularly moms, are not great at being able to even know what their symptoms are. And I would say there's a lot of people that struggle with being able to articulate that.
Yeah.
Because the belief that they don't matter, that their health isn't as important as their kids or their partner. And even sometimes the confidence that is required to sit in front of someone who is considered like, maybe not that anyone is superior over anyone, but a lot of people feel like a bit intimidated by a doctor.
Yeah.
The confidence required to just like lay all your symptoms out is actually really rare.
Yeah.
And so it's
That's
like,
hard.
how do you know your symptoms and then have the like courage, strength, and like self-worth, or like the belief that you even matter to be able to even do this, which is complicated.
Especially if you've already had a bad experience with your doctor, which again is like common. And that's why people end up talking to us, because they're just like, this is what my doctor said, this is what they did, they told me I'm fine, and they're getting annoyed with me, and you know, like they're just like basically said there's nothing else I can do for you. So to then go back and be like, it's tricky. And so sometimes patients will end up choosing to see like a virtual walk-in doctor where they can make an appointment and just start fresh and be like, this is what's going on. Sometimes that can be really useful and more constructive, where they're working with someone who, although it's not good for follow-up and things like that, but just to get the basics covered, it can be a good tool.
Yeah. And what I say to people is, from that piece of like being able to articulate what you're feeling, is when people are going even to see a specialist or a doctor, it's like, can you pre-write it down? And it's super fine to pull it out and be like,
100%.
I just need to read this to you. And that's great.
So you don't forget. And that's something that I do with my patients, is when I write their lab and diagnostics in their lab section of their recommendation sheet, I'll then write their symptoms that we've gone over that pertain to what we're wanting to get done. Right. So they have like this few sentences on exactly what I've kind of put together as the rationale, which is all based off their own experience, but I've just like taken the chunks that they need to then make it make sense. And so that is helpful. And then they can either rewrite that or show them. I just say, just don't start up by saying, do this. That's the only rule. Yeah. Don't do that.
And if you don't have you to do that for them, it's like, how do you start noting what you're feeling? And then like, it's okay to write it down.
Yep. Totally. 100%.
So what would be the things that you would want someone to not ask for, but like, what would I ask you for if I was your patient?
Yeah. So based off of, we're talking about fatigue. So we're talking about that one symptom, not that other symptoms of yours don't cross over with the cause. And that's where kind of flipping back to the symptom list that we talked about last episode, but let's just go over the testing. So if you're fatigued, and we're putting aside the fact that you're crazy busy, have many kids, are burnt out, all that kind of stuff, your cortisol is crazy. Putting that aside, the tests that we'll go through are specific to the top 5 reasons why I see women coming in and that there are these things going on that are contributing to how they feel, which is exhausted. So one would be iron. So to test for iron, it's not as easy as just testing for iron. We never really use iron as a test. Like iron, the word, is not a test that is ever really put on a requisition for fatigue. It would be your CBC. So that shows your red and white blood cell count, but most specifically, if you're developing an iron deficiency or a B12 deficiency, that'll come up in how your red blood cells are showing up. So in your hemoglobin, your MCV, your MCH, these numbers will be skewed if you're on the extreme end of deficiency. This is like now almost medical emergency where like you're really going down. So this is like late stage. So if someone just runs a CBC for you and it looks normal, it doesn't mean anything.
Okay.
So that you can just take that off the table. So CBC would be the one thing that we always do. Then we'd run your ferritin. So your ferritin is an indirect marker of your iron stores. So that's probably the most important thing for iron.
Okay.
But if we're getting to the nuance of iron deficiency, we also have to run your CRP, which is a marker of inflammation, because inflammation can falsely elevate your ferritin and mask an iron deficiency. So you have to have them run at the same time. Because if you, let's say, if I went in when I was acutely unwell last week, like with an upper respiratory tract infection, your ferritin would actually look way higher because you're all inflamed. Your immune system's upregulated. You're actually inflamed. You're on fire. So it just masks the deficiency on blood work. So that's really important. And then in very rare cases, let's say your CRP is high, then we might do even a deeper dive into transferritin or total iron binding capacity, because that will give us more insight into like the inflammation and the iron deficiency.
Okay.
So that's iron. So there's a lot more to it. So just make sure you've looked at your labs and you've actually confirmed, like, if your doctor did test your iron, because that's the term we use.
Right.
You're like, well, they tested my iron. I was like, well, no, they didn't. So look at your lab work, review it, see what was actually done. Yeah,
Okay.
go back, flip back. B12, so that's another one. So that's a deficiency that we talked about. And this is interesting because there's some nuances with when and how to test, but just B12 on its own is a test. So it's just B12,
Okay.
right? And let's say that your B12 is normal. And this is what like a lot of people get tripped up on. So B12 is normal, looks good. But if you are someone who is a poor methylator, and this is like getting now into genetics, like you as a human, genetically, how you're wired, if you're a poor methylator, let's say you have like a nice old steak for dinner. So you're eating your steak, it's really good, high in iron and B12. We love that for your energy. You know, you break your steak down, broken down, you have perfect digestion. So you're getting so much out of the steak, it gets into your bloodstream. But then genetically, you don't have the capability to add a methyl group to your B12. So it's a chemical process that happens in your body where you have to add this group to the B12 to actually allow B12 to act on anything in the body, to do its job in the body. So if you're a poor methylator, you have the B12 floating around to measure, looks good on the test, but you're not methylating, you're still going to have B12 deficiency symptoms.
Poor methylators.
And this is common. It's like 30 to 50% of people have some variation of this. So it's not uncommon. And the only way that you can really actually like know if this is happening is genetic testing, which doesn't mean for sure that it's impacting you, but you can do that, or testing something called MMA, which is not on your like normal lab test, which can give you like, is this happening to you or not? So yeah, that's B12. So it's fickle. Like you have to work with someone who has a keen eye and understands the nuances of all this.
If you have some of these fatigue symptoms that aren't like making sense, because
totally.
I mean, looking to look is probably not what most people are doing, but it's like if you're so tired and there's no answers.
If you have symptoms,
like,
this is where we start going for sure.
Yeah.
Next would be thyroid. You know a lot about thyroid and thyroid testing. So standard testing through GP would be running something called TSH, which is something that, again, you would have to be experiencing hypothyroid and developing it for maybe even a decade before the TSH would actually be out of our reference range, because it's usually not something that just like boom one day. It's like you go from normal thyroid to high thyroid or low thyroid for that matter, unless there was like a weird thing that happened where you got like an infection and it triggered an autoimmune condition that like switched on really fast. But typically it's like a slow burn. It's like brewing for years and years, and symptoms get worse and worse and worse and worse until TSH finally decides to like finally get out of the reference range, but you've been feeling like shit for 10 years. Like that's usually what happens.
Sounds terrible.
Yeah. So TSH, there's the reference range, and then there's where we want you to be, which is below 2.5. But then there's even normal TSH below 2.5, where if you don't test your actual thyroid hormones, which is T4 and T3, your TSH can look normal, but you can actually test the hormones that do the job in the body. They can be low.
Right.
But in our medical model, those hormones get canceled, so they don't get tested if your TSH is still within their very large reference range. So hypothyroid will go missed for 10 years or more sometimes before you actually get diagnosed. So it's hard to get diagnosed when you're early stage symptomatic.
And like I've had great GPs trying to get my T3 and T4 tested, and they simply can't.
No,
like
canceled.
They've tried to order it in different ways. They have an understanding of these things, but as soon as I get to the lab, and they've tried like ordering it for me in different ways, and then the lab just cancels it. So they don't have it set up for me to pay for it. So like they're like literally my hands are tied. Like the GP,
even if they wanted to.
And I've had more than one that does. It's just they literally can't because of like GPs are also bound by a very complicated system.
And algorithms.
Yeah. And then their hands are tied.
Yeah.
So, I mean, we've tested T3, T4. Like I've done that with like a naturopathic doctor because that's helpful.
Yep.
But the only way, from my understanding, unless your TSH is off, is to pay out of pocket.
Pay out of pocket. Or if you get referred to a specialist, whether that's an endocrinologist, which is someone who does specialize in hormones, they can override. But most specialists, like rheumatologists, anyone really can. So if you have a specialist, they're the ones that they actually don't get canceled. So sometimes people get lucky and they can just go through their specialist and then they'll run them. So that's like the loop. Outside of me, that's the loop in the system, but not everyone has a specialist. Most people do not.
No.
Yeah. And then other like autoimmune screeners in the thyroid world would be anti-TPO and anti-TG, which is more testing for Hashimoto's thyroiditis and Graves. So hyper and hypo, but even if you have high functioning thyroid, you can still be fatigued from it.
Right.
So both sides. So we always want to run the autoimmune markers because in most cases, it's generally autoimmune in the Western world. We're not dealing with like iodine deficiencies and other things that are tipping the thyroid.
Right.
Generally, it's more autoimmune in nature. So a lot of people get, diagnosed with a high TSH, but they never get the autoimmune markers. And then they're like, why did I just have to keep changing my medication dose because my thyroid's never stable. It's like up and down and all around. I'm like, did anyone tell you that you have autoimmune thyroid issues and that's why it's never stable? Because your immune system dictates what it wants to do on any given day.
Yeah.
So
that's me.
Yes.
Hashimoto's, baby.
Fun.
Yes. Okay. Any other tests?
Yeah, just vitamin D. And this one's a bit more straightforward. It really is just 25 hydroxy vitamin D. So that's the one test that you would do if you have a history of like fracturing yourself, you're older and you're breaking bones, like you really suspect vitamin D or the SAD. We talked about that. So that's just the one test that we do for vitamin D deficiency. So there's not really a lot of nuance outside of kind of what I was going to talk about testing, which is what do you need to do to prepare for these tests? Because just like fasting glucose and fasting insulin, there's particular instructions that we need to follow in order to make sure the tests are accurate.
Okay.
So just a few basic things that I'll say is that with thyroid particularly, you always want to go first thing in the morning.
Right.
So timing is really important, and you don't necessarily want to take your medication before because that will make your thyroid hormones and levels look better than what they are. You can take your medication as soon as you're done. Let's say you go at 7:30, take your medication at 8, but your levels will be more accurate if you do not take your medication. But timing matters is because your thyroid hormone just naturally through the day improves.
Right.
So you want to have a consistent base. So testing at the same time regularly, where it's going to be consistent. And later in the day means you've already taken your medication. So it's just really important. First thing, as soon as you can, just go in, don't take your medication. You don't need to fast, but it's good to just do it at that time. So that's thyroid. Iron. It's not as important to not take an iron supplement prior to, though there can be some recommendation around washing out for about a week, but I'm not super picky with that one because it's not as fickle. But vitamin D and B12, if you're going to test those, you do have to have a really long washout period to make sure that what you're testing is your new baseline and not just what you're orally consuming close to the test. Because there's one thing to put it in your body and then you absorb it and it's circulating from absorbing that big bolus you put in, but then it has to integrate it and put it in its place, and then you have your new base. So if you just taken a huge dose of vitamin D and you go test your vitamin D, it's going to look super high. It's not accurate. So you actually need 3 weeks between the last time you've had D to when you test, and then B12 is 2 weeks.
Okay.
So that's really important. It's not time of day, but it's how long you are away from your last exposure that matters for testing.
Okay, I have questions about the thyroid one. So if I don't take my medication, and then I test it early, and then it catches something, but my medication's fixing it, is there a risk of then having too much medication, or is it just that it would?
No. So the thing is with Synthroid particular, it's like its half-life is 7 days. It's like, this is not like, it has a really long half-life. So half-life means how much of the drug is in your system, or how long has it been. How do I explain this? Half-life is how long does it take for your body to clear half of the drug?
Right. Okay.
So 50% of it's gone out of your body. So you can see that like every day you take it, that new dose has its own half-life. So you're at a pretty stable state. But if you put new medication in within like that 4-hour window of you testing, it does skew the results. It does push it up because it's acutely in circulation. Unintegrated, it takes a good 4 to 8 hours for it to integrate and be in its place. So it will just make you look like way better than what you are. And it will also change your TSH levels to make it look lower. So it just improves and makes it look like something that it's not.
It's not. It lies to you.
It lies.
Okay. This is such good information.
Yep.
You're so smart.
Sometimes.
Most times. Most times she is. Okay. But this is like, again, I say this maybe too much, but like knowledge is power. And so knowing these things is helpful.
Yeah, it can change a lot and change your treatment protocol and plan, which is like the bigger part. You're like, well, I'm being managed, everything's fine, but you're actually just not doing the test properly, right? Which could change a lot. So that's that. And then another like nutritive that a lot of people like to take for hair, skin, and nails is biotin, which is B7. That can really mess up a lot of different lab values. So you actually do not want to have biotin in your system for at least a week. So if you're taking a B complex, or hair, skin, and nail product, you got to stop it. That will interfere with what your results are saying. So that's another common mistake that people make.
So helpful.
Yeah, totally. And then with peri is like our fifth reason, like why you might be feeling tired, because of more of the insomnia symptoms that you'll get. So lack of sleep due to hormone changes. And that's something that we just don't test for. We have a ton of like other information podcasts on testing in perimenopause and why not, but it just doesn't make sense to do testing. It's not going to give us any meaningful information if we test your progesterone, your estradiol in this phase of life. It just won't give us the information as far as like, why are you not sleeping because of your hormone imbalance? So just kind of know that. And if you're interested in learning more about it, we have a lot of information on it in previous episodes.
But also knowing what not to test is knowledge, and that's power too. So that's good.
So you don't need to, and still like,
because people will say like, my doctor didn't test, like they obviously don't know. And it's like, well,
no, but these are the things that they do want to be testing, what we just talked about for sure. Yeah, that makes sense.
Okay. Helpful. Any other comments about this one?
I think that's it. Pretty clear. So now you've got like the list of things, kind of how to approach your doctor, whoever that might be, how to go about it. And if there's any hesitation, walk in doctor, try that out, because that's definitely an avenue. Symptoms first. That's the takeaway.
Yeah, and notice your symptoms.
Yep. Notice and then write them down.
Okay. Well, if you have any comments, questions, concerns, write them below. We'll answer them to the best of our ability. If you have any other things you're like, I'd really love you wonderful people to talk about this thing, tell us. We'll do it. Or try to do it, unless it's weird. But we might not. Or maybe we will.
Oh my God.
Okay. So thank you for being here. We're happy to have you along on this journey with us. And yeah, see you soon.
See you next time.
Bye.